Great. Thank you so much, Sanil. And thank you, everyone, for being here. It is indeed actually my pleasure to be with you all. First of all, I just wanted to say that thank you all for being part of my talk. And what I mean by that is that I'm pretty sure everyone in this room has been touched by mental illness or problems with mental health in some way, either personally or somebody that they know. So thank you, all of you, for being part of my talk. The second thing I want to do is to understand who you guys are, who is my audience, right? Some of you might know a lot more psychiatry than I do. Some of you might have spent a long time in a psychiatric hospital. Some of you might own startups or technology. So perhaps I should ask a little bit about the audience. Who here is involved in, say, for example, technology? Could you put your hand up? Wow, good to see. Who here is a clinician who sees patients? Good to see. Who here is somebody who's had, if they want to share, a personal experience of the mental health system in a minor way or a major way? Thank you. Thank you. Who here is in design, thinks about design systems? And who here is doing an MBA or studying for another degree at the moment? And who have I unwisely missed out? And what do you guys do, the ones I've missed out? What do you guys do? Media? Scientists? Startups. So all very important people, very important. Thank you. I said great minds do not think alike. So just like we all have different roles, we all think differently about problems. So the issues in mental health are the same issues that we have in healthcare in general. But in my perspective is that these are greatly magnified, and that central part, stigma, is something that is a great burden to people who have mental health issues, to people who treat them, to people who try and come up with solutions or technologies or ways of empowering them. Let's think about the globe. And if I asked you where you were, and your response to me was, oh, I'm on planet Earth, that wouldn't be a very precise way of me understanding your location. But in many ways, that's where we are with mental health at the moment. Because we have this categorical assessment where we kind of lump people into these big kind of clusters of behaviors. We don't really understand the biology in many ways. What's the next step? The next step may be get a little bit more precise. So if I ask you where you are, you might say, well, I'm in North America, or in our case at the moment, we're in Australia. So let's get a little bit more precise, and we start to think about it in terms of some of the rating scales that we use and severity scales, and we're moving away from this all or nothing. Do you have depression or not? What type of depression do you have, and how severe is it? Can we get more precise? Well, this next step might be something that technology could help us with, to get very precise, to get quantitative, to say, hey, we are in a lecture theater at Melbourne University, and I'm in row 4, I'm in seat 6, and to really understand what we're dealing with. Let me give you an example about depression. So when I say depression, what do I mean? The actual term that we often use is major depressive disorder, and this is the term that we use in a book called the DSM-5, which is a textbook, a guidebook that we use for diagnosing conditions. Now, depression. Depression is a collection of symptoms. Depression is not something that we diagnose with a brain scan or with blood tests or with any other tests, just a collection of symptoms. But what's interesting about this collection of symptoms that a group of human beings, clinicians, psychiatrists, and others have deemed to be major depressive disorder is that there's over 200 different combinations of symptoms that can result in a diagnosis of depression. And this is actually a pretty conservative figure, because if you actually nuance it out, it could actually be many, many thousands. But let's just take this conservative figure. And what does that tell us? That actually tells us that 2 different people can be diagnosed with depression, but share very, very little overlap in their symptoms. Their symptoms can be very different. But once they're diagnosed with depression, oftentimes the way that the system is designed, they could be treated in a very similar way. So then are we surprised that oftentimes only a third of patients respond to an antipsychotic, to an antidepressant to start with? One of my friends, Eiko Fried, from the University of Netherlands, put it to me another way the other day when I was talking to him. He said, oftentimes you psychiatrists, say that these are the different symptoms and you count them all the same, when the reality is that people put different emphasis on different symptoms. For somebody, it could be not sleeping is their big symptom, but if they have 3 or 5 out of 9 symptoms, I'm treating them all the same. So different symptoms impose a different degree of impairment on somebody. And for some of you in the audience, you may think, well, that makes sense. But for some reason in our system, it doesn't. What is depression? So once we've clumped people into this group, the other thing that we find is that oftentimes we have a lot of overlap with all these other conditions, like eating disorders, like anxiety, like personality disorders, like problems with alcohol and other substances. And it's not only these conditions, it's also a lot of different medical conditions. There's a tremendous amount of overlap with diabetes and cardiovascular disease. So, okay, so we're not doing a great job here, but at least the researchers have got it right. But have they? And can we do it better? So is it time to reimagine our scales, our research scales? So again, I went back to my colleague and I asked him to use this image. Now, he took the 7 most common depression research scales. And in these scales, they put out 52 of the most, they had 52 depression symptoms. And what he found was kind of a little bit upsetting to me because these are really common scales that he looked at. But he found that 21 of these symptoms only appeared in one scale. And then only 6 of these 52 symptoms appeared in all 6 scales. So what we're finding is that a lot of these symptoms aren't in all the scales. These aren't the same scales. These aren't measuring the same things. So what are we measuring? We need to kind of figure that out. So we need to figure out what we're measuring, and then we need to also bear in mind that who's seeing these patients? What is the most common clinician to see somebody with depression? And this is from the US. So in the US, it tends to be a primary care physician. And I trained as a family physician in England, so I know that primary care physicians are very busy. There's a lot of different conditions they have to treat. Sometimes there's not a lot of time in the office. And a lot of times it's down to the primary care physician to make these diagnoses, to monitor these patients, to know when to refer. But I want to tell you something else about this, because when I designed this slide, I was thinking about what is the most common clinician. The reality about who sees people with major depression, with major depressive disorder, with major depression, is actually no one is seeing them, because the vast majority aren't seen or don't receive treatment. The ones that do don't receive optimal treatment. But there is hope, because there are a variety of converging paths that may help us overcome some of these challenges. Are they going to totally solve the problem? I doubt it. But are they going to help us? Yes. And are they each accelerating one another? Absolutely. So we have here computer science. And what I mean by that is not only just data science, but different hardware solution, material sciences, wearable technologies, sensors, miniaturization, things like that. And then we have advances in genomics, in some part, aided by computer science, and enhanced understanding of neuroscience, again, aided by computer science. We also have this one's actually quite important to me. Some changes in our cultural understanding, some improvements in terms of design thinking coming through, and also we have a lot of businesses and startups starting to look at mental health and say, hey, can we do things differently? Can we have some impact? It takes millions and decades to train a psychiatrist, somebody like me, but technology, minutes to produce a report, seconds to download an app. You could run a VR, AR simulation, something I'm involved in very, very quickly, sometimes almost instantly. So we're actually facing a global mental health crisis, and we have to find out what we're going to do. So are we going to get more human clinicians? We're costly, take a long time to train. We're going to use more technology? It looks like it. Are we going to get people to take care of themselves in a better way? Well, the wellness model. And that looks like it's going to be on the rise. Can we reduce demand? I'm not sure that's going to happen, at least in the short term. This is a very interesting slide. And when we think about global mental health, and again, this is actually from the US, but mental health disables and cripples us at a very young age relative to lots of other conditions. So when you hear people talking about cancer, cardiovascular diseases, respiratory diseases, bear in mind that if you look at age 35 or 45 on the chart, that orange line is actually mental and behavioral disorders. And how high it is represents how much disability there is. And you can see that it overshadows all the other disorders. So it's actually a significant cause of disability for younger people. Not only that, not only does it have personal costs, but it's projected to have a huge economic cost. These are some figures from China and India projecting out to 2030. It's going to be one of the biggest causes of economic burden. In the US, our suicide rates are rising, which is, again, a big source of concern. And suicide is a top 10 killer in general, never mind in our youth, where it's actually much higher. In Canada, I think it's number 2 amongst 15, 34-year-olds, for example. So it's a problem in a wider sense in North America. So when I talked about technology and business, well, there's some startups that are kind of emerging in this space. And as you can see, there's actually a rapid rise in a number of startups that are looking at having some impact in this space. And those startups are kind of all over the place, spread throughout the globe. Some in New York, some in San Francisco. You can actually see there's a bunch down here in Australia. And those startups are focusing on lots of different areas. They're looking at virtual reality, for example. They're looking at businesses, matching patients and clinicians together, trying to understand how to monitor mood and detect deterioration early. They're looking at social media monitoring. They're looking at patient education, video therapy, patient portals, peer support, and a lot of different sources. One thing that I like about this audience, it's got a mix of people. And it's very important to understand perspectives. Part of that is understanding that clinicians often look at symptoms and try and diagnose. So when you're having that conversation, bear that in mind. When you look at neuroscientists, often people who have a neuroscientific training, especially in behavioral science or neuroscience, start to think about circuitry, not necessarily chemical imbalances, but what kind of circuitry is affected in these disorders. Technologists may look at code or apps or systems. And startups look at product. They try and understand the market, trying to understand what kind of technology is going to actually be viable. One thing I've missed out here that's actually extremely important is patients. What's unique about patients is that they're only really patients when they're in our hospitals or in our offices, because 99% of the time, they're just people. So we have to bear them in mind whenever anyone's thinking down any of these routes. The other thing is, when does a disorder actually become a disorder? Because there's a whole movement in terms of people with autism, for example, who say, I'm an autistic person. I'm not a disordered person. I don't have autism spectrum disorder. I am autistic. So we have to also respect that some individuals may feel that their brain is a unique brain and not a disordered one. And these are some cultural shifts that we're finding. People are increasingly looking at technology. And a lot of the startups I mentioned are actually looking at smartphones. So these little things that we have in our pockets. Why? Because most of us here probably have a smartphone. And they're full of sensors. They can find out where we are, when we're calling, when we're texting, who we're texting, what we're surfing. And what's interesting is this loop, because this loop is actually perfect for behavioral health. It's actually perfect for mental health issues, because they can collect all this information, how fast we type, our voices, and then they can actually analyze it and give us directly a digital intervention. Now that's different to a lot of other conditions where you may definitely need a medication or you may need a surgical procedure. This is what makes these type of technologies really ideal for mental health. There's a lot of different technologies coming to mental health. Machine learning tools, wearables, immersive technologies. Sometimes I call that perceptual technologies because they change your perception. Things like virtual reality, augmented reality. Apps, for example, on phones. And I mentioned, are the tools already in our hands? But what I want you to pay attention to is, do we have a digital signature? Do we each have a digital signature, a digital thumbprint that's unique to us when we're healthy and when we're having a particular mental health issue? And can we detect that difference? Do we have a baseline and a problem line? And then if we know that, can we redefine that in that gross categorical kind of diagnosis that doesn't make a lot of sense when you look at the science? So there's lots of different apps for mental health, lots and lots and lots of them. Variable quality, variable usability, some potentially harmful. We've got a long way to go before I'm going to go as a physician and recommend things from the App Store to my patients. But people are going ahead and developing games. This particular one actually was recently published in Translational Psychiatry, quite a high-impact journal. This is actually a serious video game. I like that because Achille labels their technologies as such. And using this serious adaptive video game, they managed to assess cognitive function in children with a particular genetic defect that puts them at risk of ADHD and autism better than conventional tests. There's some people working on suicide prevention apps that have been shown to decrease some suicide-related behaviors, but not all. Again, in a very brief manner. This is a very interesting bit of research that came out recently. Can you detect autism based on how a child interacts with an iPad? Based on just having a normal app running, how they're interacting with the screen and how they're physically moving it. So they actually detected children with autism compared to their peers with an accuracy of 93% using machine learning. Imagine that. Imagine how many people have iPads and these technologies at home. You could run an app and you can actually analyze based on how kids are moving it about and using the screen. And very powerful. So some other companies are actually starting to put apps together with different types of pills. Like Pfizer actually released an app recently as a companion to their medication. There are some avenues in terms of, this was recent bit of research, using an additional nutraceutical, something like omega-3 fish oils, a particular type of omega fish oils, to enhance antidepressant function if you're already on an antidepressant. People are also expanding out of just simply like an app on your phone, but looking much more broadly. Looking, example, on your social networks, on your physiologic markers, on your eye blink, on doing voice analysis, doing a actual analysis of your facial affects, something that I actually do, and I'll show you in a moment. But we should also be cautious, because with everything that's good, there's always a dark side. These are digital technologies, and we have to pay heed to people who might use them for ulterior motives. I haven't seen anyone mention they had PTSD or trauma from an app. I've not seen that. But I work with a lot of people creating some extremely immersive virtual reality content, for example. And it makes me think, at what point could that potentially happen? Just a point to ponder. I like this quote by Sir William Osler. Listen to your patient, he's telling you the diagnosis. And that leads me on to using computerized speech analysis, which in this study was actually shown to detect people with extremely high rates of accuracy who are high-risk individuals that later went on to get schizophrenia by analyzing their phrase length and the semantic coherence in what they were saying. There was another study which analyzed the text conversations of different counselors. Now, thousands and thousands. Let's see how many there were. There were 15,500 conversations. And quantitatively started to figure out what makes a good therapist and what makes a therapist who struggles. And the good therapist spent more time really clearly delineating what the problem was their patient was presenting with. Spent more time in this problem-solving mode. And then actually managed to ascertain when things weren't going well and changing tack. And that was done in a very quantitative way. Okay, how many of you have iPhones? iPhones? I'm sure there's more than that. iPhones? Yes, okay, good. But not so good if you have a mental health issue. This is me asking Siri. I mean, I didn't want to overdose, but I'm just giving an example. I want to overdose. I'm not sure I understand. I told Siri I was depressed. Siri couldn't give me any help. It was only when I told Siri I was going to kill myself that Siri offered me some help. This was in the US. On most of the different mental health symptoms I actually asked Siri about, I didn't get any assistance. But Siri is supposed to be one of our more advanced conversational agents. We also know there's a lot of eye movement abnormalities and mental health disorders. This gives us an avenue to diagnose and treat as well. A lot of virtual reality technologies on the horizon. It's an example of a virtual reality study done to help people who have delusional ideas. They feel other people are kind of staring at them, looking at them. And they just made the tube in London more and more crowded, this virtual tube, and tried to use therapies while they were in this virtual environment, successfully as well. This is some of the work that we do at BrainPower. We use augmented reality technology to help children and adults with autism learn important social and cognitive skills. They effectively teach themselves these skills. Let me see if I can run this brief video.
When you look at me, it makes me think we haven't really before, because you're looking at me differently.
But the AFTEC software is already being used in the medical field to try and improve lives.
What do you see on screen?
Mom.
8-year-old Matthew Krieger has been diagnosed with autism.
A lot of the trouble he gets into with other kids is he thinks he's funny and doesn't read at all that he's not, or that they're annoyed or angry.
Matthew's mother Laura signed him up for a clinical trial being conducted by Ned Sahin.
I want to know what's going on inside the brain of someone with autism. And it turns out parents want to know that too. You get points for looking for a while, and then even for looking away and then looking back.
Sahin's company BrainPower uses Affectiva's software in programs Matthew sees through Google Glass. These games are trying to help him understand how facial expressions correspond to emotions and learn social cues.
One of the key life skills is understanding the emotions of others, and another is looking in their direction when they're speaking. Looking at your mom, and while it's green, you're getting points. When it starts to get orange and red, you'll slow down with the points.
Am I looking at you?
You are looking at me. Are you looking at me? Do you think you are? Yes.
Well, I don't know if I am.
You don't know?
Because I found out that if I look this way, it doesn't count. But if I look at the screen at you, I can still see your eyes, and it gives me points.
So, but if you tilt your head up and look under the screen, you feel like you are looking at me?
No, I feel like I am both.
Just a few minutes later, the difference in Matthew's gaze overwhelmed his mother.
I'm going to cry.
Why?
When you look at me, it makes me think we haven't really before, because you're looking at me differently.
The brain learns very well by feedback. We don't know for sure yet, but we're going to find out if the kind of feedback we're giving can help people teach themselves these skills.
After the testing, Laura Krieger reflected on what happened.
It's such a difference. And I've heard him even tell the psychologist when she works on eye contact, he says, well, I have a trick. I look at your forehead. And that's probably what people see in passing, is that counts for them as eye contact, and it did for me. But this was really different. Like, this was looking at me.
So I'm just going to make a point about that video. One of the tough things about mental health is that oftentimes the people that have mental health issues, they would benefit from help in the educational system, in the social system, sometimes in the healthcare system, both for mental health services, but for physical health services, which they often lack. And in the US anyway, and to some extent England, they get fragmented care. It's not a hot topic, not a sexy topic, but it's very real. There's a huge gap. So one of the things that will be very useful when all of us are kind of coming together in these situations is to think about how can we address this chasm that isn't being addressed when we have siloed institutions that are designed to treat an infection or to help with reading, but when somebody comes in with complex needs, it's very difficult to address them. I'm probably a little bit short on time, so I'm just going to step forward and say that there's a lot happening in terms of machine learning. Machine learning is when you basically throw in a whole bunch of data, and the computer doesn't need a hypothesis. It manages to kind of sort out and figure out special connections in the data as it goes along. You give it a set of data to learn from, and you subsequently give it data to actually test its assumptions. That can help with diagnostics, help with predicting how the disease trajectory occurs, help with predicting treatment, and also help with predicting outcome. And this has been useful in a variety of studies, helping to predict, based on baseline data, who is going to go on to be high risk and unfortunately commit suicide. Predicting out outcomes for first onset psychosis. So psychosis is this loss of contact with reality, and this is often the first point at which people go on to develop schizophrenia. And actually what's really interesting there, if you look, one of the most important factors is actually having a job, occupation. That goes on to that other point that I said, we have to support people in multiple different areas. Also, in a very limited way, I should stress that, helping to predict out what antidepressant, singular in this study, was effective for an individual based on baseline data. Again, something that we can't really do clinically very well at all. There's a lot of research happening in social media. The research quality is not very robust, but for example, this was some research looking at different Instagram filters. And so the first one it's just no filter, but the second, third, and fourth go on to kind of increasing levels of depression based on a screening assessment that was done. But people are looking at Twitter, at Facebook, at Instagram, and other social media tools to help understand people's emotions when they're, for example, depressed or suicidal or anxious. I mentioned genomics, so I should at least give you a slide on genomics. One of the interesting things with a lot of the genetics research, and there's actually been some very interesting machine learning genetics papers recently, is that when we look at these kind of discrete categorized disorders like depression and anxiety, and in this case we have ADHD and schizophrenia and bipolar, is that there's a lot of genetic overlap. There's a lot of genetic overlap, which suggests that these aren't as discrete as we're boxing them in terms of these symptom clusters. As you can see, these are the different genes. Right in the middle, in this one study, it's a Neuroinformatics research paper, there's 15 genes there that actually are shared by all 5 disorders. So what are the big barriers to mental health care? If you're making an intervention, does it work? Is it actually useful? Does it help the people you're trying to serve? What is the evidence for that? Who's going to pay for it? This is unfortunately a reality of the situation. If you live in a ivory tower, you can come up with the best strategy for somebody. 24-hour this and 24-hour that. But if there's no way of actually getting that care to them, it's really fundamentally important that we make real impact. So I've talked a lot about lots of different things because there's an awful lot happening. There's an awful lot more I could have talked about, which I'm actually going to talk about at the Psych Scene Symposium on Saturday. But I want you to take a minute and think about mental health. And there's a lot of changes that are going to happen. We're going to have autonomous vehicles within 36 to 48 months. Cars are going to drive themselves. It's going to change our commute. We're going to have automation take out a lot of lower-paying jobs. We're going to have our cities actually change based on some of these changes, just the city layouts, how many parking spots we need, in the US anyway. So based on that, there's some things that are going to happen. Most people with severe mental illness do not have jobs in the US. Some figures say 80% or more. They don't have jobs. They don't have employment. But we know that employment is actually critical to outcomes. These people feeling that they're a meaningful part of society, having an income. So what happens when automation takes their jobs, takes their first job? How do we build a system that enables these individuals to contribute to society, get on the employment ladder, if these essential first jobs where people build their fundamental skills and become part of society become automated? The second point was, for some people who are going to benefit from autonomous vehicles, what happens to our commute? We know that for every minute of commute time, we become less satisfied with life, we become more anxious and less happy, based on actually some British statistics. So what happens when cars are actually doing all the work for us and we're just inside them? What happens to that environment? Does that become another office for us? Does that become an opportunity for therapeutic intervention? What happens to this autonomous vehicle zone that we're going to have? And lastly, what's going to happen to our cities? At the moment, if you want to travel from place A to place B, you put it into Google Maps and it shows you the fastest route. Historically, you would have looked on a map and found the shortest distance. In the future, would it be possible to find the least stressful route based on your personal needs, based on your sensitivity to sound, to your comfort with different social situations, to even physical health issues, the amount of pollution or the amount of traffic? So what happens when cities, we can understand the stress and mental health burden of cities down to a kind of granular level? And there's actually some research being done in Boston to track different professionals as they go around the city and how stressful they find different areas. So can essentially we understand the city and create an environment that's better for our mental health? Can we design for mental health? Okay, that's it. Thank you so much for your time.